Welcome to our webinar series on everything you wanted to ask your doctor about sex, but were afraid to ask. My name is Brooke Hernandez, Physician Relations Liaison here at the University of Chicago Medicine. During today's webinar, we will be reviewing the causes of female sexual dysfunction, discuss menopause and sexual function, and explore treatment options. I would like to introduce our speaker for today. We have Dr. Monica Christmas. Dr. Christmas is the Director of the Center for Women's Integrated Health and the Director for the Menopause Program. We will have a Q&A session at the end of the presentation, so please utilize the Q&A feature located at the bottom of your screen. Without further ado, I'll turn it over to you, Dr. Christmas.
Hello, everybody. I'm going to share my screen so I can pull my slides up and we can jump right in. This. All right, Brooke, can you see the slides?
Yes.
All right, perfect. So we're going to talk about sex today and problems that might occur and how we can fix them. So what is sexual dysfunction? Sexual dysfunction can be a lot of things. It could mean loss of desire, decreased arousal, or some people may say decreased libido or decreased sex drive, inability to reach orgasm, pain with sexual activity, and some people unfortunately can have all of the symptoms. Contributing factors, there are lots of things, and we're going to start out talking about menopause, and we'll spend a lot of time there, not because menopause is bad, but oftentimes that's a point in time in life where people start to notice more, I'll say changes. We're not going to put good or bad connotations with things, but things might be different. And some of those different symptoms may be contributing to some of the dysfunction that people may have. Underlying medical conditions is a big area. Sometimes the medical condition itself can impact pelvic pain, any bodily pain that you're having, even if it's not in the pelvic region, can impact our arousal or ability to even impact our libido because we're feeling poorly from these underlying conditions that we have. Some of the medications that we're using to treat the condition also can impact sexual function. So it's a double whammy. I'm not feeling great because I have this cardiac thing going on, or I was diagnosed with a cancer, and then I underwent surgery. So surgery is further impacting how my body feels and how I'm able to respond in a sexual way. And now I'm on medications that may also be confounding that. History of surgeries, I talked a little bit about pelvic surgery, but things like hysterectomies, surgery for endometriosis, colon surgeries, especially people that end up needing colon resections. Those commonly are surgeries that impact our pelvic floor function and how we feel. And so we'll talk a little bit about how we can one, prevent things from happening. Maybe as we're planning the surgery, have a plan for preventing scar tissue or things from happening. But if you've already had surgery and you have some issues, how we can manage those things and make it better. History of physical, sexual, or mental abuse impacts how we respond in an intimate way. Negative sexual attitudes, and that includes a negative self-image too. Oftentimes, as we are getting older and better in many ways, our bodies are changing. We might have gained weight with menopause in general, especially when our estrogen levels drop. We start to lose muscle tone, and that muscle is replaced by fatty tissue. Much of that fatty tissue lands in our midsection. I can't think of a worse place for it to go. But how we see ourselves certainly can impact how we feel sexually. We talked about surgical things, so especially if you've had surgery that impact how our bodies look, that can impact our attitudes about ourselves. And if we're not feeling good, again, impacting sexual function. And then how we bring a lot of baggage to our intimate relationships too. And if we grew up in families maybe where sex was a more of a taboo topic and no one talked about it, or we've been in relationships in the past where we didn't have great communication skills, and maybe it didn't matter so much when we were younger because our libido was different. But now as we start to have these changes that happen in older life, those being able to communicate becomes much more important. And so if we've never done that before, it's hard to start those conversations with a partner, especially if they've been a long-term partner. Stress is a major contributing factor to sexual function. It's hard to think about being present and intimate. I always tell people that orgasms or sexuality starts in our head, not in the genital region. And if we're not able to get out of our heads, it's going to be very difficult for our bodies to respond and enjoy pleasure in that way. And then the last one that I'll touch on is relationship discord. And that could mean that there's some relationship dynamics where the relationship isn't where we want it to be. Communication is poor, as I discussed before. But sometimes our partners are having medical or issues with their sexual function, and that's impacting us as well. I'm trying to move to the next one. There we go. How common is sexual dysfunction? It's really common, and depending on what sources you look at, that number that I've quoted might change. And it's not that somebody has all of those issues. It might not even be problems that are extremely prevalent or last a long time. Sometimes things can be fluctuating. But I would say that it's pretty common. And that the incidence of sexual dysfunction increases as we get older too. And there are a lot of reasons for that we'll discuss. I've put this little upside down U to show this peak because some of the sexual dysfunction is just normal, natural, physiologic change. Our hormone, or sex hormones, I should say, peak in the mid-20s. And they start to decrease even in our 30s, and they start to level out in the 60s. So, having conversations with young people about abstinence has never been effective because that's the point that people's sex hormones are the highest. And likewise, if we are in our midlife or later years expecting that our sex drive is going to be the same as it was when we were younger, is probably not a realistic expectation either. And so I like to level set with people and really try to understand what their issues are so that we can then talk about, well, how are ways that we can minimize things, but are your expectations as realistic as they should be too? And again, that's not a good or bad or judgment conversation. It's just putting the reality of things out there. So can something be done? I think that's why most of the people decided to join this call today. And the answer is yes. But it depends on what the issue is. And I wish that I had a magic pill or a magic patch that was going to fix all of it. And even if the issues are due to menopause, I still don't have a magic fix for it. And oftentimes it's a multimodal or multi-fact, because it's multiple factors that are impacting our sexual function. Sometimes the treatment involves a multimodal approach too, where we have to try different things. So treatment categories, I will say the most common reason after menopause that people start to have sexual dysfunction is because lack of estrogen causes the vaginal tissue itself to change. The tissues become thinner, they become drier, the vaginal canal actually tightens and maybe even shrinks a little bit. The glands themselves in the vaginal area can also make less lubrication. And if the vaginal tissues are thin, dry, friable, not really stretchy, the vaginal canal is tighter, there is no surprise that there may be discomfort with any type of vaginal penetration. And so if the symptoms are just mild, using over-the-counter lubricants and moisturizers can actually be very helpful, and we may not need to do anything else. Moisturizers and lubricants are different. They're not the same thing, and they're not all created equal. Often, many of the over-the-counter agents have alcohol in them. They may have fragrance or perfumes. There may be preservatives in them too, and those agents can be irritating as well. So it's important to read labels and get something that doesn't have alcohol, that's pH balanced with the normal pH of the vagina, and doesn't have many additives or preservatives, and certainly nothing with any fragrance to it. A moisturizer is something that you're going to use on a regular basis just to bring more moisture to the vaginal tissues. It's like lotion. If you put lotion on your skin today, but don't put it on again until next week, it's not going to work so well. And that's the same for vaginal moisturizers. You want to use them. It doesn't have to be every day, but you're going to want to use it at least 2 to 3 times a week to get the maximum benefit. Hyaluronic acid-based vaginal moisturizers tend to perform very well, even in randomized control trials. So there are a couple of brands on the market of hyaluronic acid-based moisturizers, and so I tend to recommend those. I get asked a lot about, well, what about coconut oil or olive oil, vitamin E oil? I've even been asked about vegetable oil or glycerin. You know, many, I'm going to call them the cooking oils, oftentimes can have a smell to them or odor. So I don't think that's a great thing. But sometimes I think they also increase the risk of bacterial vaginosis and yeast infections. So I'm not a big proponent of coconut oil in the vagina, although there are a number of people that swear by it. And if it's working for you, I'm not going to knock it. But I do think that hyaluronic acid-based moisturizers are good and don't have those irritating side effects. A lubricant is something that you're going to use with sexual activity or vaginal penetration. So you can actually put the lubricant on the vaginal tissues themselves, on the penis, on a device like a vibrator that you might be using. And the lubricant is to decrease any friction, pain that's with friction. There's different types of lubricants. There are water-based lubricants, there's silicone-based lubricants, there's oil-based lubricants. The oil-based ones, if you're using a condom, can break the condom down. So if that's a concern, either for contraception with a condom or wanting to use it to protect against sexually transmitted diseases, you're going to want to stick with either a water-based lubricant or a silicone-based lubricant. The silicone-based lubricants can be really tacky or sticky, so some people don't like that. Water-based lubricants are not going to have that tacky, sticky feel to them, but they'll dry out a little bit more quickly, so you may need to reapply often. Slippery stuff is one that our pelvic floor physical therapists recommend. You can get it on Amazon. It's water-based. It has no alcohol in it, no preservatives, no fragrance, so it's pretty gentle to the vaginal tissues. If vaginal moisturizers and lubricants help a little, but not enough, and you're still feeling dryness or discomfort, low-dose vaginal estrogen therapy can be helpful too. And low-dose local vaginal estrogen is very different than systemic doses. So one thing too, though, since it is different and it's not systemically absorbed, it's not going to do anything to help hot flashes or night sweats. So that might be a downside, but the upside is that because it's not systemically absorbed, some of the contraindications that people have for using systemic doses aren't the same for these low-dose local doses. In addition, we don't tend to put people on systemic dose hormone therapy forever. Most of us will say if you're over the age of 60 or within or more than 10 years from the onset of menopause, that we're thinking about an exit plan, because the risks start to outweigh the benefits when we're using systemic dose hormone therapy later in life. That's not the same for local low-dose vaginal estrogen. We don't have a limited time frame on that, and we don't have, again, the same contraindications. There are a number of different vaginal estrogen options. There's a vaginal cream, a vaginal pill, a vaginal suppository or an insert. And those are used twice a week. What 2 days you use it doesn't much matter. If you forget one day, no worries, you can do it the next day. And then there's a vaginal ring that's pretty nifty, because you put the ring in the vagina, you don't feel it, your partner shouldn't feel it. And it can stay in place for 90 days. At the end of 90 days, you pull it out, throw it away, and then you would put another one in and keep it moving. Although the lubricants and the moisturizer are just providing temporary relief, giving estrogen back to the vaginal tissues actually is changing the dynamics and the structure of the vaginal mucosa so that that vaginal tissue is a little bit more like your premenopausal state. If though somebody either just does not want to be on estrogen, or they have strong a contraindication, maybe there was a history of breast cancer, and we can actually even consider using local low dose vaginal estrogen patients who have had breast cancer. But I understand some people just say the word estrogen scares me and I don't want to use it. There are two non-estrogen options on the market. One is an oral pill called, the generic name is ospemifene. The brand name is Ospina, but it is a SERM, a selective estrogen receptor modulator, meaning it's not estrogen, but it does act like estrogen on certain tissues. And one of the tissues that it acts like estrogen on is the vaginal tissue. It does have a protective benefit to the breast, so that's a good thing. It's not impacting breast tissue like estrogen would, so in a negative way, but it does have a positive effect on the vaginal tissues and works rather well. It is a daily pill, though, that you do have to take every day. One of the side effects is that early on, it may make your hot flashes come back or a little bit worse. So if hot flashes are an issue, this probably may not be the best option for you. The next option is a steroid or DHEA insert. It breaks down into a phyto or a plant-based estrogen and some testosterone too. It is used daily, so it works really well, but it's a little cumbersome that you have to use it every day. And so that's the thing that often makes patients not really want to go for that option. Anytime we anticipate something being painful, our body tightens or recoils. If you think someone's going to hit you or something's going to drop on your foot, you tense up. It's no different with vaginal pain. If intercourse has been painful and we are anticipating it being painful again, we tense our bodies up. And it's almost like doing weightlifting for the vaginal muscles, and we can make it so tight that it almost feels like there's a barrier there. Surgery, pelvic floor surgeries, whether it be a bowel or colon surgery or vaginal surgeries or hysterectomies, bladder surgeries, sometimes can cause scar tissue that can tighten or cause stricture to the vaginal walls. And radiation therapy to the pelvis also can too. So any of those things, vaginal dilators can be very helpful because it can help not only stretch out the caliber of the vaginal walls, but help the vaginal muscles get used to something being there too. And dilators come either in a set where they are very small and they incrementally get bigger, or there's a single dilator called the milli that you put in at its smallest diameter, and you control it with a remote control to increase the size of the diameter, which some people like better than having to take something in and out. But that's the circumstances I'll get. Well, why would I need to use a dilator? Is if we need to stretch out the vaginal muscle walls. Vibrators and anything that provides clitoral stimulation. Not only the vaginal dilator can help, the vibrator, can act like a dilator as well to help mechanically stretch out those vaginal tissues. But just the vibration and the stimulation also can stimulate the glands in the area to have more secretions. And it also stimulates the nerve endings in the pelvic and the vaginal area as well. When all of these things still haven't quite gotten in, and especially in somebody who has pretty tight pelvic floor muscles that are clenched down, pelvic floor physical therapy can do wonders. And it's not something that you have to do forever. It usually, once we teach people the exercises, after a few sessions, you're on your own and don't need to continue to go. It's not intuitive. So I do think sometimes it's not something that you can all of the time teach yourself, because sometimes we're not aware or have the self-awareness that we're tightening those pelvic floor muscles, and how to relax them is not always intuitive as well. And then lastly, I have here sex therapy. And sex therapy is very different than regular therapy. Not that regular therapy is bad, but sex therapy is different. We're really fortunate at the University of Chicago to have two wonderful sex therapists, Dr. Amy Siston and Dr. Elise Fidel. But one of the good things that came out of COVID is that we pivoted to a virtual platform too. So there are a number of sex therapists, if there's not someone in your area or you can't get into one of our University of Chicago providers, that you could even access somebody in a virtual way and not have to go in. What about testosterone? And testosterone pellets are pretty popular right now. So I feel like on a daily basis, I'm getting asked about pellet therapy. There are no testosterone, FDA approved testosterone options, I should say, available for women in the United States. So when we use testosterone, we are using either male approved medications, and we're giving it at a significantly less, usually it's 1/10 of the dose that you would give a male, or we're getting them from a compounding pharmacy where somebody is making a cream that you rub on daily. Has been shown in randomized controlled trials to be effective in post-menopausal women that have hypo or have decreased libido. I was going to use the fancy term for it, but essentially it's having a decreased sex drive that has been present for over 6 months, and all other factors that we've talked about have been addressed, and those are not an issue. So this is somebody who says, I am in a great relationship, my partner is extremely supportive, there is no relationship discord, I'm not under any more stress than I usually am under, I am lubricated, I have no pain with intercourse, I even can have orgasm if I engage in vaginal penetrative intercourse. I just have absolutely zero desire, and it's bothersome to me, and it's impacting my relationship, because that's a big part of the diagnosis, is that it has to be bothersome to the patient. And so that is where a short-term use of transdermal testosterone is, even though there are no FDA approved options for women, that we consider it safe and effective. Pellet therapy or other injectables are not recommended, and the risks far outweigh the benefit. Pellet therapy in particular can significantly increase the testosterone levels to a very high super physiologic dose that can increase the risk of cardiovascular disease or blood clots, or even pulmonary embolism or stroke. So pellets are not recommended. The FDA has issued a warning statement. The American College of Obstetricians and Gynecologists has a warning statement against bioidenticals and pellets, as well as the Menopause Society and the Endocrine Society. Side effects even of the lower dose creams that I talked about that we can use, some can cause hirsutism, like male pattern hair growth. So, hair in areas that you don't want it in, and some patients will notice that they have thinning hair on their head. Could increase the risk of acne, and it could be on the face or chest. Deepening of the voice, and clitoral enlargement with higher doses that we should be avoiding. And then what about flibanserin or bremelanotide? These are two medications that are approved, again, for decreased libido that has been an issue for more than 6 months, and there is no other physical or even psychological reason to account for it. They are FDA approved medications, but they're only FDA approved for pre-menopausal women. There are some limited studies that show that the risk in postmenopausal women, especially for flibanserin, is not any different than the risk for premenopausal women. There are no studies in postmenopausal women for the injection, though. Side effects for both of the medications are dizziness, feeling drowsy or tired, nausea and fatigue. And so you think, oh my good, well, I shouldn't say what you think. Oh my goodness, those side effects are nothing that I would want. That seems like it would go against what you're trying to do. And then there's a black box warning regarding against alcohol use while on the medication. So flubanserin is a daily pill that you would just take every day. And bremelanotide is an injection that you take before intercourse. Because of the significant risk, and one that I don't have on there is hypotension too, your blood pressure may be dropping. You have to sign a consent form. I have to sign a consent form. And then when you go pick it up from the pharmacy, the pharmacist has to sign a consent form. And so oftentimes I think people get a little spooked or scared with all of that. And when we're using it, often the insurance company doesn't cover it either. So the cost can be prohibitive as well. But they are two options available for, again, for hyposexual disorder. Does Viagra work for women? And the data is conflicting. It may help with lubrication, but the side effect profile is pretty high. And so there are other things that we can use for lubrication that are safer. So this is not one that I tend to use. If somebody does give it to you, you're supposed to actually take it in the doctor's office the first time, wait 30 minutes, and then have your blood pressure checked and other vital signs to make sure that there's not an adverse reaction to taking it. Laser therapy, is laser worth the cost? So there are lots of different, like Mona Lisa is one. I don't want to pick on Mona Lisa because there are other laser therapies. And so we all really were excited about laser a few years ago because we thought, especially in patients that have contraindications like a history of breast cancer that can't be on estrogen, that this might be just a fantastic option for them. And what laser does is it makes all of these micro perforations in the vaginal walls by putting a probe in. And then once those micro perforations happen, there's supposed to be regrowth of the vaginal epithelium. And lasers are used for lots of other dermatologic or medical conditions and have shown efficacy. So there was a lot of hope that this was going to be really beneficial for managing the atrophic vaginal changes that happen after menopause. And the data just didn't show it. It doesn't really show that laser therapy is better than sham therapy. And because the cost is so high and the data is not really supportive, it's not one that I recommend, nor does many of the major medical professional organizations. There's also a pretty high placebo effect with really with herbal and vitamin things, but really for treatments for sexual dysfunction, the placebo effect can be up to 40%. And what is a placebo effect? It's where you give half the people in the study the real treatment, and you give the other half of the people in the study a sugar pill, or in the case of laser, they would get a sham laser. And what happens is that early on, most people say they feel better. It doesn't matter if they're in the placebo or the sugar pill group, or they're in the real active treatment group. And it's the same statistical significance, no difference at all. And then usually what happens after a few weeks, nobody feels better. So, you know, things like black cohosh, maca, evening primrose oil, chasteberry. I'm trying to think of all of the herbal things, even cannabis that people have asked about. I've heard that this helps. Most of the trials, if there are any trials, they're small. And there's only a few people in them, and they've given everybody the medication, and everybody says they feel good over those first couple of weeks. And so people jump on it and either publish that, or that's what they put in their little package insert. But when you do the randomized control trials, what we see is that there isn't really any difference. So I think that's something important to remember when we're, you know, buying things or taking things, that there can be this placebo effect. And so in summary, I hope I didn't talk too fast. Good. So I've left 30 minutes for us to be able to have question and answer. But in summary, if your sexual dysfunction is due from decreased estrogen from being postmenopausal, we can, first line treatment would be using moisturizers and lubricants. If that doesn't work, then either using one of the low dose local vaginal estrogen therapies or that steroid suppository that I've mentioned, or that oral pill, the SERM. If the vaginal dryness has been taken care of, so dryness isn't the issue anymore, but there is a vaginal spasm, or there's a feeling like the vaginal walls have closed in, then, and that is called there's a name for that, genital pelvic pain penetration disorder, or GPPPD. And it's those involuntary spasms of the vaginal wall. That's where pelvic floor physical therapy and either use of vaginal dilators or even a vibrator can be very helpful. Decreased libido or low desire, again, addressing any type of underlying medical condition that might be impacting sexual function, changing medications, certain antidepressants, certain hypertensive medications can impact sexual function. So if there's an option of changing medication, I always try to do that first. If there's not an option for changing the medication, then we can work on things. Is doing something like sex therapy helpful? And it's not that the sex therapy is going to fix the underlying medical condition that's going on. But again, like I said, sexual function stuff starts in our heads, not in our genital area. And if we can start to think about things in a more positive way and not put a negative connotation on it, or start to think about our sexuality different. It might be that we need to do different things to help stimulate us. I talk a lot about using or introducing, I'm not going to call them toys, I'm going to call them tools for helping with sexual function that leads right into the anorgasmia category, which we'll get to in a second, can be very helpful. And so talking with the sex therapist to talk about touch, how we can communicate better with our partners, how we can start to think about sexuality different than maybe what we thought about it before either our illness or before our surgery or before our radiation therapy or before if there was any type of physical, mental, sexual abuse that's impacting sexual function. I think that's where sex therapy is extremely helpful. And then I know I didn't make any of those pharmacologic or those medications sound very promising, but we do have some of those in our toolbox too. And then anybody that's having orgasmic disorders, it could be somebody that's never had an orgasm before, or somebody that had them, but because of the medical condition or because of menopause, they're having more difficulty reaching orgasm. Just aging makes it a little bit more difficult to reach orgasm. We need to stimulate that clitoris a little bit more. Most of the nerve endings and for our I guess female sexual pleasure are in that clitoris, and so most women are not actually able to orgasm without having clitoral stimulation. And there actually really is something. There's a science behind vibration. There's a certain vibration level that actually helps stimulate those nerve endings more so than even just touch. And that is why things like vibrators or even the ERAS, suction cup, that's a medical device that has been approved for anorgasmia, help with sexual function or stimulating, bringing more blood flow to the clitoris. Masturbation can be very helpful too in understanding what brings you sexual pleasure. Oftentimes I think we think, especially when it's heterosexual sex, is that something magical is supposed to happen when the penis goes into the vagina. And for most women, they don't reach orgasm just with vaginal penetration. There needs to be some clitoral stimulation, and some of that clitoral stimulation may need to come from a vibrating device. So I think I have actually talked enough. I'm hoping we have at least 30 minutes right now to answer your questions. I'm going to stop screen sharing. And Brooke, I don't know, is there a way that I guess I just see you, so I also don't see anybody else.
I don't see anyone else, but we have some questions that have come in, so I will read them to you. And just to let everyone know, very anonymous, so do not be shy to ask any questions. You can use the Q&A feature at the bottom of your screen. So no one will see your name or the question that you ask. So please use that feature if you want to ask a question. Here's a question that has come through. Can vibrators damage your nerves, making climaxing harder to reach with regular sex?
Yeah, no, I hear that a lot. Can you become addicted? I've had people ask me, become addicted to a vibrator. No, you cannot become addicted to the vibrator. And when to me, when somebody says that to me, it just tells me what's a normal physiologic response is that if I can't have an orgasm without the assistance of the vibrator, there's a reason behind it, is because that vibration, as I talked about, I could get all nerdy and talk about the amount of hertz that cause the vibration, and it doesn't really matter. It really is just that we do need some clitoral stimulation. So instead of, thinking about it as something taboo, which I think a lot of us do, think about masturbation or sex tools. Again, I'm not going to say toys as something that, they should be ashamed of or don't want to talk about their partners about it. But introducing that to partnered activity can be very helpful and more satisfying.
Perfect. Thank you. Another question that has come through. Does hysterectomy rush menopause?
If hysterectomy is just removing the uterus, but if the hysterectomy, the ovaries are removed, that does put you into surgical menopause because you don't have the estrogen and progesterone anymore. Excuse me, I've had a cold, guys. I should have prefaced that at the beginning of the talk. That's why I'm so hoarse. But if the ovaries are left behind, they're even just removing the uterus. Sometimes that can increase the risk of an earlier onset of menopause by a couple of years because it may compromise the blood flow to the uterus. No, to the ovaries, I'm sorry. But I don't mean it's going to, put you in the early menopause by 10 years. I think most of the research shows that maybe it's a year earlier. The average age of menopause naturally is about age 52. But the range that 90% of people will fall into is between ages of 45 and 55. But we start to experience symptoms related to hormonal fluctuations up to 7 years before we actually go into menopause. And menopause is defined as not having a period for a full year. So I think sometimes hysterectomies get a bad rap because somebody might be 45, let's say, at the time of the hysterectomy, and they start to experience, I'm going to say, perimenopausal symptoms, and they attribute it that the hysterectomy did it to me. And quite naturally, we start to experience symptoms related to hormonal fluctuations before that. So it's not actually that the hysterectomy did it, unless your ovaries were removed. Yeah.
Okay. Next question. If you stay on birth control, will you ever hit menopause?
Menopause is unavoidable. It is 50% of us, if we are born female, we are going to go through menopause. We cannot buy our way out of it. We can't take pills to get our way out of it. It doesn't matter your race, ethnicity, nothing. What birth control pills do, though, is that it is because you get an estrogen in the pill, the estrogen causes the lining to thicken, the progesterone in the pill helps it to thin. And so those weeks that you're taking active pills, you're getting the lining building up, and then you have the few placebo pills at the end, your body recognizes that you don't have the pills anymore. And what happens is you get a withdrawal bleed, right? But it's a man-made withdrawal bleed because it's coming from the birth control pill. So somebody that's on a birth control pill, it's hard. We won't be able to tell, are they in menopause until we stop the pill. So I don't know if this is what the person was getting at. So it's not that menopause increases the risk of menopause. It doesn't put you into early menopause. It doesn't prevent menopause from happening. It's just that we're giving you estrogen and progesterone in the pill. The mechanisms of the way that pill works will still keep you having a period every month. Or if you're taking the pill every day, then you won't get a period. But we really won't know where you are until we stop the hormone. So let's say somebody's on a low dose birth control pill because they were having horrible menstrual cycles. I usually will say, hey, that 90% of people will go through menopause by the age of 55. As long as you don't have any other contraindications to being on this pill, we can keep you on a low dose form of birth control until you hit 55, and then we'll take you off and see where you are. And 90% of people should be in menopause at that point.
Okay. A question. So say your mother and grandmother didn't experience any menopause side effects. Is there hope for you? This is my question.
Yeah, we do tend to behave like our family members do, but that's not a guarantee. Everybody's menopause experience is very different. Some people have very few symptoms, and some people have every symptom that you could possibly get. And it doesn't mean that something is wrong with them. It doesn't mean they didn't do something right. It's just how they're responding to this end of the reproductive phase of life. It's just like when you're prepubescent, before you get your menstrual cycle, you might not remember it, but the adults in your life might have said, oh my goodness, you were so emotional, or you slept all the time, or you were really, whatever the case might have been, and then many times some people get their periods and they always last 3 days. They're never heavy, they don't have cramping, and it's like that their entire life until one day it just stops. And then you have some people that from the first month that they get their period, it's heavy, it's long, they have cramping, they're nauseated, they got to take time off from school, and it continues like that, and it gets worse until they go into menopause. So, it runs the gamut. But the important thing to realize is that if you are having symptoms that are impacting your quality of life, there is help. Right? Just like I talked about with sexual function issues, it might not be that I have one magic jelly bean to give you that's going to fix all of the things. It might be that we have to work on lots of different things, but we can improve it. So I don't think anybody should be suffering or just accepting it.
Great. Okay, a couple more questions have come through. I've had trauma, hysterectomy, divorce, and medication, and it has impacted my sex drive. I have a real fear around the act. The desire to perform is there, but the fear is overwhelming. Please advise how to get past this.
This is a perfect case for not only sex therapy, but pelvic floor physical therapy too. I always like to start with an exam first to make sure there's not significant atrophy, because we all, we can start doing either the vaginal estrogen or one of those other options to help get the vaginal tissues a little bit more, I'm going to call it stretchy, making more lubrication. But when we have real things that have happened to us, and I'm holding my head because it's all those things that we carry up here that are creating a mental and a physical blockade, it's really important that we address those things in a way that is comfortable for you, and it can't be rushed. But I do think that we can effectively help anybody that's having issues like that get over the hurdle, but it does take some time, and I think physical therapy will help relax the pelvic floor, or learn how to relax the pelvic floor. But the sex therapy is going to help us really come to terms with what our blocks are and what's really impacting us and creating that tension in our bodies.
Perfect. Thank you. We actually had a couple of people raise their hand. I'm not sure if you guys meant to raise your hand, Karen. If you would like to speak, I will give you the floor. Did you have a question, Karen? No?
Maybe not.
Ashley, did you have a question?
I did, but she answered it while while you guys were still talking.
Okay.
So thank you.
Can you hear me now?
Yes,
Karen,
I can hear you.
Okay. I put it in the answer thing question and answer after I raised my hand. Thank you for doing this. I just wanted to say I have always preferred masturbation to intercourse. I really do not like anything at all entering my body. Is that normal? Am I atypical? Is this okay?
You know, when it comes to sexuality, really, what is your preference is going to be okay. When I tried to say at the beginning, I'm not going to put good or bad connotations with anything. And how we feel about our pleasure changes too. I would say that you probably have a very healthy outlook because you are comfortable with your own self-pleasure. You know what pleases you. And if you are not bothered by having intimacy from a partnered relationship, then it's not problematic. Where it becomes dysfunction is if you feel that is inhibiting you in some way, or that that it's that you would feel more fulfilled if you were able to engage in sexual activity with another person. But if you are fine, that this is not bothersome to you, it's not impacting anything, then no, it's not a problem at all.
Okay, thank you.
On that same vein, I did a panel discussion a few years ago, and somebody stood up in the audience and had said that they either read an article or they had heard that lesbians have better sex. And what did I think about that? And I said, well, of course they have better sex. And it's not because lesbians know something more than what we do. It's more so because it requires communication, right? If you have two people of the same sex, you can't just fall back on a penis goes in the vagina and something magical is supposed to happen. We're going to have a conversation about what's comfortable to me, what I like, what I don't like, what maybe I've done before, what I haven't done before, what I might want to explore. And I probably will have a much more open mindset about pleasure. And as Karen said, maybe I then feel more comfortable talking to a partner and saying, I actually don't enjoy anything going into my vagina, but I feel a lot of pleasure, maybe from breast stimulation or from clitoral stimulation. And then you can have that open conversation. I think the problem happens is that we historically, maybe the generation now is not as afraid. They're much more, uninhibited about having conversations like that. But if you were raised to not talk about sex and that it was just for procreation, or you shouldn't do it until you get married, and then all of a sudden you're in a situation where you didn't masturbate, so you don't know what your body likes or responds to, and you've been in a marriage for a while and you never ever told your spouse what you didn't like, and you've been faking it the whole time. You're in a situation now where I'm too scared to tell my partner that what he's been doing for the last 10 years hasn't actually really been that pleasurable to me, because his feelings are going to get hurt. And that's when menopause actually can be a great fallback, because you can blame it on that. You can say, babe, sex was so wonderful before, and I'm so upset that all of the things that you did before aren't working for me now. But I went and saw Dr. Christmas or Dr. whoever, and they told me, and we can meet with them together too, but some of the things that we did before aren't probably going to be as stimulating to me. And would you be receptive to do it? And so now we can talk about introducing some of these sexual tools, or maybe, exploring other ways of pleasure that weren't what you always did for the last 10, 15 years. And you don't have to tell him that you faked it the whole time. So.
Okay, another question. Does your sexual appetite lessen automatically with menopause?
Not necessarily. Some people are very liberated. They feel very free that they can't get pregnant anymore. Especially in somebody that had horrible periods where they felt like every 21 days they were having a 7 to 10 day hemorrhage every month. And all of a sudden they don't have to worry about bleeding. They don't have to worry about bleeding in the middle of sex. They don't have to worry about pregnancy. Sometimes that can be completely freeing. And those people will be, because again, this is a mental thing. They feel very unencumbered, and they are much more receptive or open to sexual pleasure than they were in the past. Other people, though, especially if you're experiencing extreme vaginal dryness, or if you've had changes to your appearance, like the weight gain that I talked about, and you're feeling embarrassed or shy about your body image, those people probably will have more of a decreased libido, and we can address those factors and help get them through that.
Great. Okay, next question. If I take birth control pills only when I'm sexually active, then go months without taking it, is that okay? Are there any health risks with this strategy?
Well, one is that you got to be pretty strategic, and can't have too much spontaneity. Because birth control pills you need to be on them for at least a month before they're effective as birth control by themselves. There are lots of non-contraceptive benefits to being on birth control, and they're cumulative. So there's a decreased risk of ovarian cancer and uterine cancer. And the longer that you're on the pill, the better the benefit is. It also keeps your periods light. And if somebody has cramping, it improves with that. It helps with acne. So there are a lot of non-hormonal benefits for being on the pill. Sometimes stopping and starting, it's not that it's bad, but it can be sometimes more disruptive, because I do think it takes sometimes up to 3 full cycles before your body acclimates to being on the pill. But I can certainly understand if you're somebody that's not sexually active and you're thinking, why in the world am I taking this pill every day? I'm not with the partner. I'll just wait until I'm in a relationship again to start. And there's nothing wrong with doing that.
Okay. Next question. I have MS and I am in menopause. Some days I have no idea what my body is doing. Any suggestions, articles, references on how to deal with both?
Yeah, any of the conditions that impact our neurologic, our nerve system, can be very difficult. MS is a hard one, especially if it's impacting bladder and bowel too, because if you're fearful of leaking urine or having stool incontinence, that can impact how your ability to be present. When our nerve endings are desensitized, as often are there with MS, and some of the medications with MS impact sexual function too, our nerve endings aren't as sensitized. And so, that's, I keep going back to with sex therapy, because just because something is different doesn't mean it has to be bad. And there are techniques like sensate focus or touching that, especially if you have a partner that's really receptive to doing those things with you, that can help stimulate and boost our libido, or at least our sexual response.
Perfect. Okay, another question. Once you take some of the medications that you recommended for dryness, will you have to take them forever?
Yeah, you need to take them, well, unless you don't, if you ever get to a point where you don't care about having a dry vagina anymore, then you don't have to take them. For people that aren't sexually active and the vaginal dryness doesn't bother them, then no, you don't. But for people that are wanting to engage in vaginal penetration, but even couples that aren't doing that, don't do vaginal penetration, even if it's touch, sometimes the vaginal tissues can be very sensitive without having estrogen there. So it is something that you're kind of committed to taking until you don't care about that aspect of sexuality anymore.
Oh, the other part, they say so it doesn't come back.
Your ovaries are never, once you hit menopause, our ovaries do not make estrogen anymore, or progesterone too, but it's really the estrogen that impacts stuff. And so symptoms like hot flashes and night sweats, they actually tend to get better over time, and we really don't have to treat them. But vaginal symptoms are just the opposite. Without treatment, they can sometimes actually get worse. And once we start treatment, it's not like, oh, we can cure it. It's not something to be cured. Menopause is a natural state. It's not a medicalized condition. There are just some symptoms about menopause that can be bothersome. And so it's not a short-term fix. It's something that you're always going to do. Some people realize it, especially, let's say they're using cream or a pill. You know what, doc, I don't need to use it twice a week. I only do it once a week, as maintenance therapy. So things like that can be played around with. But the reality of it is if we're wanting to maintain vaginal health. Now, if you don't have dryness or pain, then no, you don't need it. But for people that are, you need treatment.
Hey, are those all of the questions? It looks like those are all of the questions that have come through. And we are actually almost at time. We have 5 more minutes, but we have another question.
Okay.
I'm having the opposite effect of dryness. Is it normal that your vagina is more lubricant with arousal and menopause?
Yeah. If it's just normal, there's no odor, there's no itching, burning, any evidence that it is like an infection, and it's just that you're more lubricated, you're very lucky. I'm going to count you in the group of people that don't have hot flashes or night sweats, or people that their period just stops one day and they never have the irregular bleeding that people have. So you're just pretty fortunate. Now, if there's any irritation with it or odor or itching or anything, then I'd want to make sure that there's not some underlying, condition, infection going on. But it sounds like that might just be you, and you're fortunate.
Yeah, good for you.
Mm-hmm.
Another question is more of a statement. Well, is she accepting patients? She's amazing.
I am accepting patients.
She is amazing. She delivered my youngest son, although she does not deliver anymore. But
I think you might have been one of the last people I delivered.
I was. So thank you. And it's approaching. Remember, he was the Thanksgiving baby. So I appreciate you for staying and delivering. Okay, another question. Oh, well, again, thank you so much for having this conversation with us. I really appreciate the knowledge. So more of a comment. So it looks like those are all of the questions. Thank you again, Dr. Christmas. That was amazing.
One more thing I just thought about, and let me see if I can type it in. This woman asked me a few years ago, she was ahead of her game too, because it was before all the COVID shutdown stuff. She created a class called the Big O Master Class. She is a PhD psychologist out of UCLA, and her area is sex therapy. And she created this virtual program that I reviewed for her and thought it was excellent. So for people that may be feeling, I don't want to say embarrassed, but just not ready to maybe meet with one of our sex therapists in person or virtually, her virtual program is something that you can do in your house, and it really does walk you through masturbation, how to think about boosting your own sexuality and finding what is pleasurable to you. And I thought she did it in an excellent way. So I'm going to write her name in the chat. It's Dr. Erica Marchand. She has, all the social media sites too, so you can look. I don't know if she still calls it the Big O Masterclass, but it may be a good resource, especially for those that have, like the patient that talked about the MS. I think that, we can work with it, but we do have to, employ some different modalities to help get them feeling better.
Mm-hmm. Perfect. And you know what? We can actually include that in the follow-up email you guys will receive with any resources that you want to share from the talk, Dr. Christmas, so that they can have it available.
We should share Woman Lab, WOMAN Lab, LAB. Woman Lab is a group through University of Chicago, through Dr. Stacey Lindau actually started it. I wrote a number of articles for them that are on their website about menopause and sexual function. But they have everything from people that have had either radiation for cervical cancer and don't actually have a functioning vagina anymore, how to have anal sex in a safe way. There's a lot about pelvic floor physical therapy and what sex therapists do. There's information to help people get through if they had breast cancer and no longer have sensation to their breast tissue. So it's a really nice resource. And Brooke, I will, make sure we can get that to them too. But again, it's womanlab.org.
Perfect. And this actually will be, this is recorded, so a copy of the recording will be sent to all participants, as well as those that registered that were not able to attend. So please share this with your family and friends or anyone in your circle that you think will benefit from the talk that wasn't able to attend. Again, thank you so much, Dr. Christmas, and thank you all for attending. We hope you gained a lot of insight on sex and sexual dysfunction and menopause and all the drama that us women have to go through. But we have resources, so that's always the silver lining. So thank you guys again for joining, and we hope that you join us for our next one. We'll keep you guys posted on any upcoming webinar.